Hi, everyone. I'm Lisa Carey from the University of North Carolina, and I have the pleasure of moderating the Clinical Controversies session. Now, we have these, a dream team of big brains sitting up here, and we're going to ask them to help us with some of the thorniest clinical questions that are out there. And we're also going to ask them to be very disciplined about time because they have packed a lot into this session. So they're going to take as much advantage of this, this brain trust up here as we can. So what you'll see is we have Are We Ready to Stop Staging the Axilla by Drs. Morrow and Giuliano, How to Treat Small Triple-Negative Breast Cancer by Dr. Thomas and Sharma, Biology or Stage, Tailoring Treatment for Premenopausal Women with High Clinical but Low Genomic Risk from Dr. Kalinsky and Dr. Winer. All right, so I think our first one is Dr. Morrow from Memorial Sloan Kettering.
Thank you for the opportunity to discuss this interesting topic, and I have no disclosures, and if I can have my slides, I'd be happy to start. So the traditional rationale for axillary staging, that is to improve survival, maintain local control, and aid in the selection of systemic therapy, is no longer felt to be true for significant numbers of breast cancer patients. Summarized on this slide are major studies examining the relationship between lymph nodes left behind in the axilla, rates of nodal recurrence, and the impact of less versus more axillary surgery on survival. What all of these studies show is that the likelihood of nodal recurrence is substantially lower than the number of nodes left behind, and that bigger surgery does not improve survival, even dating back to NSABP B04, where no systemic therapy or radiotherapy was given, and this impression was reinforced by the excellent presentation from the Early Breast Cancer Trialists Collaborative Group this morning looking at the issue of nodal surgery. So if we're considering eliminating nodal surgery, the first question to ask is, what is the risk of axillary node metastases in someone with a normal physical exam? In these two studies of more than 8,000 patients, you see that while about 20% of women will have macrometastases, the likelihood of N2 or N3 disease is only about 3.6%. And this became very relevant with the findings in Taylor-X and R-Exponder that in postmenopausal, hormone receptor positive, HER2-negative women with 21 gene recurrence scores of 25 or less, the addition of chemotherapy to endocrine therapy did not improve survival outcomes, regardless of whether the patient was node negative or had metastases to 1 to 3 axillary nodes. Now, although we might like to think that the idea of omitting axillary staging is something new, in fact, there's been a movement to do that in hormone receptor positive women age 70 and older for a number of years now. And in addition to the rationale that I just described to you, in these women, comorbidities and life expectancy are increasingly important in adjuvant therapy decision-making. We have excellent safety data that shows us that axillary recurrence is uncommon in the IBCSG 1093 trial, which randomized clinically node-negative women 60 and older to axillary dissection versus no axillary surgery. The rate of nodal recurrence was only 3%, in spite of the fact that only about 30% of women in this trial received radiotherapy. In CLGB 9343, in the patients who did not have axillary staging and did not receive radiotherapy, we again see that 3% nodal recurrence rate. So what has happened to axillary staging in women 70 and older? SSO Choosing Wisely guidelines recommend avoiding sentinel node biopsy in this group. NCCN declares that it is optional. But if you look at these studies from the National Cancer Database in the United States through 2016, you see that almost 90% of women undergo a sentinel node biopsy. And even if you look at women over the age of 85, which is the orange line on the second graph, half of them undergo sentinel node biopsy. But in spite of the rather resounding failure to eliminate sentinel node biopsy in those over 70, there is great interest in expanding this concept to postmenopausal hormone receptor positive women under the age of 70 years. Summarized on this trial are some of the ongoing studies asking this question. You will note that all of these studies enroll women who are undergoing breast-conserving surgery with whole breast irradiation. The first of these trials, the SOUND trial, was reported recently, and in this study, clinical stage 1 breast cancer patients with a negative axillary ultrasound were randomized to no axillary surgery or sentinel node biopsy followed by axillary dissection if nodal metastases were present. Although the eligibility criteria for this study were broad, it was overwhelmingly a study of postmenopausal hormone receptor positive HER2 negative women. What we see is that the incidence of macrometastases was only 9%, and 4 or more positive nodes were present in only 0.6%. So given the low rate of nodal metastases, it is not surprising that axillary recurrence was extremely uncommon. It was seen in 0.4% in both arms. Total local regional recurrence did not differ, and 5-year distant disease-free survival was 98% in both groups. Statistical non-inferiority was demonstrated. So this study should provide reassurance to those of you who are worried that eliminating axillary staging in this group of patients will deprive large numbers of women of the benefits of chemotherapy or CDK4/6 inhibitors because the incidence of N2-3 disease was at 0.6%. I think there are more important questions about radiotherapy. If you believe that all T1N1 patients need nodal irradiation, you will undertreat 9% with this approach. But there's a bigger chance of overtreatment since current guidelines for partial breast irradiation call for node negativity. And as shown this morning by Dr. Jagsy, studies looking at the elimination of radiotherapy altogether in low-risk genomic groups, such as the IDEA trial, require histologic node negativity. So in conclusion, in clinically node-negative postmenopausal patients with hormone receptor-positive HER2-negative cancers, axillary staging adds morbidity but does not improve survival, is not needed for local control, and influences systemic therapy decisions in a very small minority of patients. For those undergoing breast-conserving surgery, we can safely eliminate axillary staging, but I think we have to ask ourselves the question, is this really what we want to eliminate given the trade-offs with radiotherapy? For those having mastectomy, there are limited data, but the likelihood of nodal metastases does not vary based on the breast operation. And for everyone, I think it's clear that sentinel node biopsy is less morbid than radiotherapy, which is given due to the inability to accept any level of uncertainty about nodal status, and successful de-escalation is going to require multidisciplinary agreement. Thank you.
Our next speaker is Dr. Armando Giuliano from Cedars-Sinai.
Thank you. I'm so happy I finally have a disclosure. It does not relate at all to this talk, however. I think we've seen at this meeting, and in fact for decades, that axillary treatment itself for the clinically node-negative woman has no measurable impact on survival. But what I hope to show you is that it may provide information contributing to survival and alterations in management. Dr. Morrow has very nicely just shown us how we can eliminate axillary staging for women, certainly over 50, with small ER-positive tumors. But what I hope to show you is that nodal staging with a sentinel node biopsy usually influences therapy and may alter outcome for women with other types of breast cancer. Although our exponder has shown no benefit for chemotherapy in postmenopausal women with low recurrence scores, the premenopausal woman with positive nodes may benefit from chemotherapy regardless of the recurrence score. In addition, ovarian suppression and prolonged endocrine therapy may improve prognosis for high-risk premenopausal women. Therefore, sentinel node biopsy is important for all clinically node-negative premenopausal patients. That begs the question, is it important in other subtypes of breast cancer where the adjuvant therapy may be determined by the biologic subtype itself. So let's look at that. This APT study examined the treatment of women with small, less than or equal to 3 centimeter HER2-positive cancers with pathologically negative lymph nodes, pathologically negative nodes. And this study showed extraordinary 3, 7, and 10 years disease-free and overall survival results with de-escalation of therapy. So a tumor-free sentinel node for the patient with a HER2-positive breast cancer less than or equal to 3 centimeters can result in de-escalation of systemic therapy. On the other hand, the Catherine study showed that for women with residual disease after treatment with neoadjuvant therapy for HER2-positive disease would benefit from escalation of therapy with TDM1. This treatment resulted in about a 50% improvement of disease-free survival. Therefore, an involved sentinel node may escalate systemic therapy and alter regional nodal treatment for patients after neoadjuvant therapy for HER2-positive disease. So nodal metastases change the adjuvant therapy for smaller HER2-positive tumors, and women treated with neoadjuvant therapy will benefit from alterations in therapy if they have residual disease in the node. Sentinel node biopsy is necessary for most women with HER2-positive breast cancers. Similarly, the CREATEC study examined the use of capecitabine after neoadjuvant treatment for triple-negative breast cancer. These women who have residual disease benefited greatly from the use of capecitabine. So patients with residual disease after treatment neoadjuvantly for triple-negative breast cancer benefit from capecitabine and/or possibly studies of immunotherapy and certainly alterations in nodal management with axillary dissection and/or axillary irradiation. Remember, no imaging modality can reliably identify residual disease after neoadjuvant therapy. Despite the fact that we rely on ultrasonography pre-treatment, it is not as effective in identifying residual disease post-treatment. Can you have residual disease in the axilla if you have a breast PCR? This large study and many other studies, smaller studies, have shown that axillary-only disease exists after neoadjuvant therapy for triple-negative or HER2-positive disease in about 10, 15, or 20% of cases. So an involved sentinel node after neoadjuvant therapy alters management. Dr. Morrow briefly touched on this, and I would also like to mention this. Often the inappropriate omission of axillary staging results in increased use of nodal irradiation that may also be inappropriate. So sometimes axillary staging is necessary to define when a patient needs nodal irradiation. In summary, axillary staging is necessary for the premenopausal clinically node-negative woman, the HER2-positive tumors less than or equal to 3 centimeters, and all subtypes of breast cancer after neoadjuvant systemic therapy, even if they appear to be clinically node-negative. No method detects axillary metastases as effectively as axillary surgery. Sentinel node biopsy is not for all, but is essential for some. Thank you very much.
So since we have this wonderful multidisciplinary panel up here, we're going to do all of the talks and then we will have the questions afterwards. So write them down and we'll have a question and answer session. But our next speaker is Dr. Alexandra Thomas from Wake Forest.
Great. Hello. Good afternoon. I'd like to thank the organizers for the opportunity to discuss this very important topic, how to treat small triple-negative breast cancers. Dr. Sharma and I elected not to debate each other, but to really challenge or to debate our community as to how can we get it just right for our patients with this disease. My disclosures. So to put this conversation in context, let's consider what we mean first by small triple-negative tumor. By convention, we tend to consider tumors that are 2 centimeters in size and node-negative small. They have a lower event rate relative to their counterpart not small tumors, and in large part due to this lower event rate, these patients have been largely excluded from most systemic therapy trials. Today, we also rely largely on pathologic size for these tumors. However, as we move forward and increasingly consider studying or even adopting new adjuvant approaches for these patients, we may need to rely and be comfortable with imaging-based assessment of these tumors. The definition of triple negative also has some room for discussion, as ER and PR have historically been considered less than 1%, though now some trials are allowing for tumors with expression of these receptors up to 10%. In addition, triple negative breast cancer is a highly heterogeneous disease with tumors across the spectrum of risk. While the event rate for this population is lower, this represents a lot of patients, and this is why we'd like to push our field towards thinking about this. We in the clinic see a lot of patients with T1 and 0 triple negative breast cancer, making this an important space for us to start thinking about. Data from SEER found that approximately 1/3 of patients with stage 1 to 3 presentations of triple negative breast cancer were T1 and 0. Other SEER-based work has shown that the portion of T1AB tumors as a portion of stage 1 to 3 presentations is also increasing. For this afternoon's discussion, we'll look at what is known with regard to prognosis, role of biomarkers, optimal systemic management, how guidelines direct us in this space, as well as looking at knowledge gaps and avenues for research. I'll first turn the lens to the smallest of invasive triple-negative breast cancers, T1AB. Dr. Sharma will then walk us through where we are with T1C disease. Let's consider this in the context of a case, a 58-year-old with grade 3 triple-negative breast cancer who appears to have a 9mm tumor on imaging that's clinically node negative. So what's the natural history of T1AB triple-negative breast cancer? The study I've shown here, conducted at MD Anderson, looked at patients who presented with T1AB disease who did not receive chemotherapy from the early 1990s to the early 2000s. Until recently, recall, chemotherapy was the only agent that we had for these patients. 143 of the patients they studied had triple-negative tumors. Their recurrence-free survival and distant recurrence-free survival are shown in the blue curves in the first two figures. As with T1AB, HER2-positive tumors, shown in black, now widely studied and treated with APT, the survival for the patients with the small triple-negative tumors was inferior relative to the patients with hormone receptor-positive tumors, shown in red. Is age a biomarker for risk in this group? Here, the data are mixed. In this particular cohort, young age was associated with numerically inferior recurrence-free survival, but not perhaps the more important distant recurrence-free survival. Notably, as is often the case in this retrospective work, numbers are small and confidence intervals wide. So with this understanding of the natural history, let's ask, how does chemotherapy improve outcomes for this cohort? Shown here are the results of multiple large retrospective data sets which looked at outcomes of those who received chemotherapy relative to others who did not. While there's a wide range of apparent benefit, there is a trend, and not surprisingly, towards more benefit for those with larger tumors, larger small tumors, and an unclear pattern with regard to the benefit associated with age. Several studies reported inferior outcomes for younger patients who received chemotherapy. For a variety of reasons, the studies and these comparisons need to be reviewed with caution. In particular, and this is a weakness in this space, most notably all studies were retrospective and therefore have inherent biases with regard to who received chemotherapy and who did not, as well as who accessed care at these centers. Diving just a little bit deeper into Dr. Vasilewis's work, looking at outcomes separately by T1A and T1B tumors, we see that both groups appeared to have numeric benefit to chemotherapy, though again, numbers are quite small and confidence intervals wide. So can we tease out better which patients with T1AB tumors might benefit most? The large Dutch cohort of over 4,000 patients with significant follow-up of 8.2 years included approximately 30% of patients with T1AB tumors. They again saw benefit for larger tumors and also for those over 60 years of age. There was also a trend towards more benefit for those with high-grade disease. And while we often use age in decision-making for chemotherapy in this group, it is notable that based on retrospective data, younger patients do not appear to have a markedly different natural history with this disease, nor do they appear to benefit from chemotherapy per se. Importantly, the relative risk of treatment as well as relative benefit in terms of years of life to protect may impact individual risk-benefit discussions around this scenario. So what do we know about newer biomarkers that's specific to T1AB tumors? It turns out not as much as I'd like, though the Koreans did have this small study looking at outcomes by stromal TILs in triple-negative T1AB tumors, and they saw, just as we've seen with larger tumors, that significant stromal TILs is associated with improved survival. So how will biomarkers evolve as we increasingly refine risk assessment for these many, many patients who we see with small triple-negative tumors? Today, I think many of us in the clinic use tumor grade, patient age, and individualized discussions. Increasingly, we're discussing stromal TILs and tumor boards. The formal guidelines are pending. And I'd put forth that hopefully in the very short term, we'll have highly reliable markers of minimal residual disease, which can inform risk-benefit conversations in this scenario. And we need urgently to study these. Current guidelines for chemotherapy with T1AB triple-negative breast cancer vary quite greatly, as shown here, with some recommending chemotherapy for most and others not recommending it at all. This likely reflects the current paucity of high-level evidence in this space. There are some revisions which may bring these slightly more into alignment, though high-level evidence would be helpful. So key knowledge gaps in the space that I'm hopeful, and Dr. Sharma hopeful we can collectively address, is how can we more precisely identify who can forego systemic therapy? What about what chemotherapy-sparing options might emerge for this group? And can we harness the potential benefit of neoadjuvant therapy for these patients? And in which patients should we use this approach? How can we get answers for our patients with T1AB triple-negative breast cancer? We can develop more trials, and as you've heard, I'd encourage us to study biomarkers and potentially neoadjuvant approaches. We can also utilize real-world, contemporary, perhaps even prospectively collected evidence. Finally, can we extrapolate, as you'll hear in a few moments, from the more well-studied T1C space and apply some of the lessons there to these smallest of tumors? As we look to address these gaps, clinical trials will be critical. I want to shout out to our Dutch colleagues who are leading EORTC 2257. In brief, Optimal will look at stromal TILs, incorporating this into therapeutic decision-making and trials of T1 and 0 triple-negative breast cancer, and it will include the smallest triple-negative tumors. Returning briefly to our case, how would we approach decision-making for a 58-year-old with 9mm node-negative tumor? I'd favor a clinical trial, a registry if available. Outside of a trial, I would consider chemotherapy on a case-by-case basis in discussion with the patient, though based on what we know today, would recommend neither checkpoint blockade nor platinum. Thank you.
Good, thank you. And her clinical bookend for the question of triple negative, as we get into the slightly larger small node negative, triple negative, is Dr. Priyanka Sharma from Kansas.
Good afternoon. Thank you for the opportunity to discuss this topic, and thank you, Dr. Thomas, for this eloquent discussion of the smaller within the small triple-negative breast cancers. These are my disclosures.
Yeah, just the green.
So let's go back to the same case, but now with the tumor size of 1.5 centimeters, making it T1C disease. T1C disease accounts for about 60 to 70% of all stage 1 triple-negative breast cancers, so it's a very common clinical scenario that we all encounter in clinic. Most of our insights about prognosis without chemotherapy in T1C disease comes from retrospective studies. A retrospective study of 265 patients where 90% of patients received adjuvant chemotherapy showed 5-year recurrence-free survival of 93% with chemotherapy and 47% without chemotherapy. In the Netherlands Cancer Registry data that included over 4,000 patients where about 2/3 of the patients with T1C disease did receive adjuvant chemotherapy, receipt of chemotherapy was associated with improved breast cancer-specific survival when controlled for other clinical and pathological variables. Given the suboptimal outcomes without chemotherapy, most of our guidelines are consistent in recommending chemotherapy for T1C disease as opposed to T1AB, where there's a lot of variation, with just one caveat of low-risk histologies where this chemotherapy can be omitted per the ESMO guidelines. Let us review the available evidence regarding adjuvant chemotherapy regimens for stage 1 triple-negative breast cancers. A very few adjuvant trials actually included stage 1 breast cancers. Phase 3 trial that compared 4 cycles of AC to 4 cycles of docetaxel cyclophosphamide in HER2-negative breast cancers included a little over 200 patients with T1C disease. However, patients with triple-negative breast cancer accounted for just over 60 patients in this subgroup. TC was associated with better disease-free survival over AC, and on exploratory subgroup analysis, the benefit of TC over AC were noted in all subgroups, including triple-negative breast cancer and lymph node-negative disease. The ABC trial included over 900 patients with N0 triple-negative breast cancer. However, the breakdown between T1 N0 versus T2 to 4 N0 was not provided. The 4-year IDFS was better with the tax-AC regimen compared to 4 cycles of TC. And on subgroup analysis, AC tax was superior to TC in all triple-negative subgroups, including those with N0 disease. These data suggest that if only 4 cycles of either anthracycline or taxane-based adjuvant chemotherapy is considered, 4 cycles of TC is superior to 4 cycles of AC. However, if both anthracycline and taxane are combined in the adjuvant regimen, tax-AC is superior to TC for triple-negative breast cancer. Patton was an adjuvant trial that compared CEF followed by 3 cycles of taxane to 6 cycles of carbopaclitaxel and showed a superior disease-free survival with the platinum taxane compared to CEF. The trial did include T1C N0, however, the exact numbers were not reported in the publication. And on subgroup analysis, the carbotaxane regimen was superior to anthracycline taxane regimen in all subgroups, including T1 tumors, mimicking the entire trial results. How about neoadjuvant chemotherapy? Similar to our adjuvant trials, most large neoadjuvant trials also did not include stage 1 breast cancers, and there are no prospective data of neoadjuvant TC in triple-negative breast cancer. A few trials did include stage 1 triple-negative breast cancer. Summarized below are a few of them. The phase 2 WGS ADAPT study showed a pathological complete response of 46% with 12 weeks of nab-paclitaxel and carboplatin. This trial had 37% patients with T1CN0 disease, and lower stage was associated with higher PCR. NeoPact included 17% of patients with T1C disease and showed similar PCR with carbopaclitaxel followed by AC and 6 cycles of carbodocetaxel. Since chemotherapy will be generally recommended for most patients with T1C triple-negative breast cancer, should we deliver this chemotherapy in neoadjuvant or adjuvant fashion? Neoadjuvant approach has several advantages. It increases breast conservation rates, eradicates axillary disease, pathological response provides valuable prognostic information, and helps us tailor adjuvant systemic therapy like capecitabine, olaparib, and even clinical trials. One could argue that breast conservation rates may unlikely to be improved for small cancers with neoadjuvant chemotherapy, and there may be concerns about overtreatment if there's uncertainty about the size based on clinical staging. However, we routinely use clinical staging to triage HER2-positive breast cancer patients for pre-op dual HER2-targeted therapy versus adjuvant APT-type therapy. So to me, this is not a major concern. For the case that we're discussing, if this patient went to surgery first, the chances of having a sentinel positive lymph node range from 7 to 46% based on the normogram used or presence of lymphovascular invasion, and neoadjuvant therapy is likely to eradicate most of this occult axillary disease. CREATE-X trial evaluated adjuvant capecitabine residual disease and included patients who presented with tumor size less than 2 centimeters. And the benefit of capecitabine was similar in patients who had initial tumor size less than 2 centimeters versus larger tumor size. The Olympia-A trial included TNBC patients with any amount of residual disease with no minimum requirement on the presenting tumor size or stage. These data strengthen the argument for considering neoadjuvant chemotherapy for T1C disease. What do our guidelines say about chemotherapy regimens? NCCN guidelines combines TNBC and hormone-positive disease for chemotherapy recommendations and lists neoadjuvant and adjuvant regimens together. Here, marked with blue arrows, are regimens that are probably most pertinent to T1C triple-negative breast cancer. ESMO guidelines, again, are not specific for triple-negative breast cancer and endorse sequential anthracycline taxane-based regimen, with the caveat for selected lower-risk patients where 4 cycles of either anthracycline or taxane-based chemotherapy or CMF may be used. And St. Gallen endorses ACT-type chemotherapy. Again, these recommendations are based on clinical trials that primarily included stage 2 and 3 breast cancers with very little representation of smaller triple-negative breast cancers. Even though chemotherapy is considered standard, there may be some patients with T1C disease who do very well without chemotherapy. A pooled analysis of 4 T1 and 0 cohorts untreated with chemotherapy showed 5-year survival for patients with TILs greater than 30% at a pretty robust level of 98%. The Netherlands registry data for patients under age 40, again, who didn't receive adjuvant chemotherapy, 10-year survival was 93% for patients who had TILs greater than 75%. This suggests that patients with stage 1 TNBC and high TILs have very good outcomes without chemotherapy. But higher TIL thresholds may be needed to select the very young patients for studies that are assessing chemotherapy omission. How about neoadjuvant IO for small triple-negative breast cancers? Again, patients with stage 1 TNBC were not included in the large phase 3 IO trials. GEPAR-NEVO did include 60 patients with stage 1 disease, and the IDFS benefit of durva was similar for stage 0 to 1 and stage 2A or higher. Tomorrow, Dr. Loy will present results from NEO-N trial, which also enrolled stage 1 triple-negative breast cancers. For T1C disease, there are specific areas of knowledge gaps and opportunities for research. First, which patients can safely forego chemotherapy? Perhaps it's the patients with the highest TIL levels, and the upcoming optimal trial will address that in a prospective fashion. We can optimize systemic therapy and agents and duration using the neoadjuvant model guided by biomarkers. Right now, there's very limited data on role of immunotherapy for stage 1 triple-negative breast cancer. However, some trials are including these patients, and we await results from these studies. For this particular patient, I would encourage participation in a trial like Optimal or something similar that is looking at treatment optimization based on TILs or other biomarkers. In absence of available clinical trial, I would recommend chemotherapy in a neoadjuvant fashion, and I would favor using an anthracycline-free platinum taxane regimen. Of course, this patient should be offered genetic counseling and testing. The current treatment algorithm for small triple-negative breast cancers is based on anatomical risk. We hope that in the near future, our recommendations will incorporate both biological and anatomical risk. Thank you.
So we've been talking now about the low clinical but high biologic, meaning from the standpoint of triple-negative conundrum. Now we're going to switch to the opposite of high clinical but low biologic risks of premenopausal node-positive disease with low genomic assay scores.
Thank you. Okay, now
Dr.
moving along.
Kalinsky.
Oh, sorry.
I forgot to introduce you. Dr. Kalinsky of Emory.
Thank you. Thank you, Dr. Carey. Now, moving along to the most straightforward of our controversies, talking about biology or stage. And I want to thank the organizing committee for the opportunity to discuss this controversy with Dr. Winer. These are my disclosures. So at the heart of this matter is that this is a clinically relevant issue. We do not want to be over-treating our patients, but we also do not want to be under-treating our patients. To contextualize this controversy, as previously mentioned, in responder, patients with hormone receptor positive HER2 breast cancer with 1 to 3 nodes involved and a recurrence score of 0 to 25 were randomized to chemotherapy followed by endocrine therapy versus endocrine therapy alone. It is worth giving the caveats that in this population, that some of our patients with higher risk features, like those who have T3 tumors, 3 nodes, grade 3, or women who are less than 40 years of age, are underrepresented in this study. And what we saw is that the chemotherapy benefit was different by menopausal status if the recurrence score was 0 to 25. And at the bottom of the slide is how menopausal status was defined, which was based upon clinical features. And we saw in the post-menopausal population, which was 2/3 of our patients, we saw at 5 years that there was no difference with the addition of chemotherapy in terms of invasive disease-free survival. And one of the questions that has come out from this population is, what about patients who have more than 3 lymph nodes involved? But that's for another discussion. For the premenopausal patients, we saw a 5-year invasive disease-free survival difference of about 5% for those who were randomized to chemotherapy. And at the heart of this matter is, why are we seeing this chemotherapy benefit? And also, just to give the contextualization, that the ovarian function suppression rate was low in this study, about 16% in the endocrine therapy alone arm. So these are my discussion points. 1, clinical risk matters. 2, younger women may have different tumor biology. And 3, not all patients are adherent to ovarian suppression. So the first point, clinical risk matters. So this is a multivariable analysis that's looking at premenopausal patients and associations with IDFS. In addition to chemotherapy and recurrence score, higher tumor size, and younger age independently associated with this outcome. And when we think about age, we see in the premenopausal cohort, the magnitude of benefit is higher for those patients who are less than 50 years of age compared to those who are greater than or equal to 50 years of age, but the interaction term was not statistically significant. I will say that there are ongoing analyses that we will hopefully report at a Congress next year that is looking at baseline serum hormone levels to help define menopausal status. From colleagues, including TaylorX colleagues, there's been the development of the RS-Clin tool for patients with lymph node negative breast cancer. And this is based upon the fact that clinical pathologic features inform risk. And in this tool, which is available within the US, is you incorporate the score, and then the quote-unquote individualized risk at 10 years of distant recurrence, as well as the absolute chemotherapy benefit, could change based upon size, grade, age of surgery. I will say earlier we saw updates from RS-Clin for late distant recurrence at this meeting, and there's also an RS-Clin in patients with lymph node positive disease that's in development. Also in MINDACT, for those patients who had clinical high and genomic low risk disease, for those patients who are less than or equal to 50 years of age, again, a third of our population, and again, patients where we saw a low rate of ovarian function suppression, we saw a 5% chemo benefit in distant metastasis-free survival at 8 years, and this chemo benefit was not seen for patients greater than 50 years of age. So second point, younger women may have different tumor biology. So these are some data, including from TCGA, where if you look at patients who are younger than or equal to 50 years of age, compared to those who are older than 55, that there was a higher immune-related expression in younger women. And we also saw that there was lower estrogen receptor-associated gene expression in younger women. And this just asks the question, could the benefit of chemotherapy versus ovarian suppression depend on whether this is associated with an immune signature or estrogen receptor signature? There are also interesting data from our SOFT colleagues, some which were published this year, which demonstrated that in younger women, as defined as less than 40, that there was a higher HRD and copy number alterations in younger women, and the presence of these associated with worse outcome. We also saw at ASCO that patients who were less than 40 years of age, that there was a higher rate of luminal B tumors as seen in teal compared to those who were greater than or equal to 40 years of age. But the other notable finding was that if you're looking at luminal A at the top and luminal B at the bottom, even for those patients who had luminal A tumors, when discriminating based upon age, that those patients who were younger had a worse 10-year distant relapse-free interval. And it is worth noting that we are awaiting publication. It will be interesting to see if we can observe any differences between adherence between these two arms, but still, this was what was reported. And then the third point along these lines is that not all patients are adherent to ovarian suppression. So these are data from SoftText, in which you can see that about 20% of patients are not adherent to oral endocrine therapy, as well as to medical ovarian function suppression. And what I'm showing you in these graphs is that that rate of non-adherence at 4 years is slightly higher for those patients who are less than or equal to 35 years of age. Also, in the ASTRA trial, which looked at giving tamoxifen with or without 2 years of ovarian function suppression, that rate of discontinuation, early discontinuation of the 2 years of OFS was about the same. And we also know that in the real world, that women who are less than 40 years of age have the highest rate of endocrine therapy discontinuation. So this is demonstrating the clinical controversy that we have, which is also serving as the rationale for the BR009 trial, which has opened. And I would encourage us to enroll to this genomically defined population, which includes those patients that we're talking about here, this responder population, in which patients are randomized to ovarian function suppression plus endocrine therapy with or without chemotherapy. I will also say that appropriately, CDK4/6 inhibitors are allowed. And it is also worth noting that there's a numeric greater benefit of abemaciclib in premenopausal patients in the Monarch E study. That magnitude of benefit in an exploratory analysis was higher in premenopausal women, also noting that in this study that the rate of ovarian function suppression was about 30%. So these were the points that I was making. Clinical risk matters. To help also bring up some of the questions, we do have tools such as CTS5, tools that incorporate genomic and clinical risks, such as potentially RS-CLIN node-positive disease, help individualize risk. Younger women may have different tumor biology, but as I mentioned, these patients are underrepresented in our trials. And are we confident that current assays help discriminate risk, including late recurrence? And not all patients are adherent to ovarian suppression. One of the questions being, well, how can we improve the tolerability of endocrine therapy that we're giving? And with targeted therapy, can this conversation become moot, and can we move away from chemotherapy? And until we answer some of these questions, we need to use our best clinical judgment and talk about with our patients what we know and what we don't know when we are individualizing therapy. Thank you.
And add a few more thoughts on this topic, we have Dr. Eric Winer of Yale.
So I'm the bookend, and I want to thank the organizers for inviting me. I have no relevant financial disclosures. So by way of background, we've known for over 3 decades that eliminating ovarian function is an effective treatment for breast cancer. This was published almost 3 decades ago, and this was both with chemotherapy and without chemotherapy, although the benefits of eliminating ovarian function are less if a woman also receives chemotherapy. And more recently, we have updated data from the SOFT trial. This is with 12 years of follow-up, a 7.1% absolute difference in disease-free survival at 12 years, comparing the tamoxifen arm with the exemestane plus ovarian suppression arm. And there is also a small and borderline statistically significant improvement in overall survival. The crux of the matter is, for patients with node-positive, biologically lower-risk disease, does chemotherapy add to ovarian suppression? And that, of course, is the question that's being asked in the NRG trial. Is the chemotherapy benefit seen in our responder all or most about its impact on ovarian function? So where are we today? Certainly, we should strongly encourage patients to participate in the NIRG trial to determine if chemotherapy does add to maximal endocrine therapy. But we're not going to have an answer to that question for, I'm told, 11 years. And only a minority of patients can and will participate in that trial, and day-to-day treatment decisions will nonetheless have to be made. So what do we know about the differences in cancers between pre- and postmenopausal women? This comes from SEER data and does indeed show that for women under 40, who were a very small minority of patients who were in our responder, that there is a decrement in terms of overall survival. Women 40 to 60 and over 60 have very similar outcomes in general. And in fact, if one specifically looks at women 40 to 49, of all decades, they have the best prognosis with the diagnosis of breast cancer. This comes from Lisa Carey and colleague from the Carolina Breast Cancer Study and looks at differences in breast cancer subtypes by age. Clearly, there are more triple-negative cancers and HER2-positive cancers, and for that matter, luminal B cancers, though that's not well shown on this slide. In women under 40, these differences seem to diminish between 40 and 50. And of course, even though there is this difference in the distribution of cancers in younger women versus those that are older, is there any evidence that young women with low-grade, low recurrence score cancers have greater benefits from the cytotoxic effects of chemotherapy than older patients? And that, of course, is a critical question. I don't think we have evidence, but that doesn't mean that evidence might not at one point exist. So this looks at the data from our responder and shows that regardless of the recurrence score, whether it was 0 to 13 or 14 to 25, there was clearly a benefit among the women who received chemotherapy plus endocrine therapy versus endocrine therapy. If anything, from the standpoint of the hazard ratio, it was a greater benefit in women who had the lowest recurrence scores. Now, I should point out that I think this runs contrary to everything that we know about the recurrence scores. And if chemotherapy for node-positive premenopausal patients is mediated via the cytotoxic effect, is it possible that it could be doing so in women no matter what the recurrence score is? So these are data from the preoperative setting. These are two different studies that correlated recurrence scores with either RCB 0 or 1 or pathologic complete response. Neither of these studies are particularly large, but it will not surprise you that they demonstrate, I think, fairly clearly that with very low recurrence scores, women are unlikely to achieve a pathologic complete response, and these responses become much more common as the recurrence score goes up. And finally, in Taylor-X, where there was indeed a small benefit for chemotherapy in individuals who had recurrence scores between 16 and 25, if you examine the group of women who have very low scores, in fact, there is no apparent benefit, and the curves actually cross at about 13, if I remember correctly. So what really matters, menopausal status at diagnosis or when endocrine therapy is actually given? So these are data that you previously saw, but in all premenopausal women taken as a whole, there was benefit for chemotherapy in our responder, but that benefits seem to arise in women who were under the age of 50. And for women who were over 50, there seemed to be no apparent benefit with a hazard ratio of 0.98. And the hypothesis from that is that all of these tumors arise in an estrogen-rich environment because these women are all premenopausal. But women over the age of 50 quickly become menopausal and experience ovarian dysfunction on their own. For women less than 50, chemotherapy often results in ovarian function suppression, which then potentially lowers the risk of disease recurrence. These are now from Taylor-X, looking at the subgroups of premenopausal women by age who benefited and didn't benefit from the addition of chemotherapy. Among women who were less than 40, there appeared to be no benefit. This represents a group of women who are very unlikely to experience ovarian function suppression with chemotherapy, certainly not permanent OFS. And among the premenopausal women, among the women who were less than 50 who had already gone through menopause, not surprisingly, no benefit. But for that matter, similar to our responder, no benefit as well in the women who were premenopausal and 51 to 55, women who would be expected to lose ovarian function on their own. In contrast, in women in their 40s, a group of women who are extremely likely to go through ovarian function suppression as a result of chemotherapy, there was a benefit. So the 40s appears to be the sweet spot, and the only way that I can explain that sweet spot is that if it's related to an endocrine effect. So for me, the bottom line is something like this. Some, most, or all of the benefit from chemotherapy in premenopausal women who have recurrence scores of 25 or less is almost certainly the result of OFS from chemotherapy. In many patients, the benefit of chemotherapy over directed OFS with an LHRH agonist or oophorectomy is likely to be minimal to none. If patients are not willing to take or are non-adherent with OFS, chemotherapy probably isn't a substitute unless it induces OFS, and I'd argue that chemotherapy isn't a very nice way of achieving OFS. So when should patients and clinicians more strongly consider chemotherapy in premenopausal women who have 1 to 3 positive nodes and recurrence scores between 0 and 25? So in my mind, I would pose that there are several situations where you would think about it in greater detail. You're certainly going to discuss it with everyone. Patients with recurrence scores in the 21 to 25 range, patients with high-grade disease, patients with features above and who have a relatively heavy disease burden, possibly very young patients, although there were very few of those patients in the trial, and I'm still not convinced, based on all that we know, that there is necessarily a unique biology in a young patient who has an ER-positive, low recurrence score cancer. Those who believe in the strict literal interpretation of RxBonder results should clearly opt to take chemotherapy, as well as patients who have a preference, having heard the nuanced data and want to receive a course of chemotherapy. But in all of these cases, I don't think it's out of the question to substitute OFS, and I'd be willing to take that approach with a patient with whom I'd had a detailed conversation. And just to point out, and as Dr. Kalinsky pointed out as well, there are also now CDK4/6 inhibitors that are more than on the horizon. Rarely are decisions black and white, and we are all left swimming in a sea of gray far more often than we would like. Thank you for letting me share my thoughts, and thanks to Kevin and Ann Partridge and a number of others.
Terrific. So we have a few minutes, about 8 minutes for questions, and we actually have some that have come in. If folks have a question and want to step up to the mic, I'm going to start with one of the questions from online, which is, do we have to escalate axillary surgery in luminal breast cancer patients with a positive sentinel node according to the results of Monarch E and the potential for using a CDK4/6 inhibitor in order to help the medical oncologist make their decision?
No. I think, as I showed you, in clinically node-negative patients, the likelihood of having 4 or more positive nodes is about 3.6%. So it's not very many. And if you then hone down on, well, if you want to look at how many patients were there from Monarch E who had 1 to 3 positive nodes, didn't have a T3 tumor, didn't have a grade 3 disease, how many patients would you benefit from performing that completion axillary dissection? Dr. Mittendorf has looked at that question, and the number is exceedingly small. So you'd be performing 100 axillary dissections to benefit approximately 4 people, I believe is the number. So if you picked out the very rare patient who had a very large T2 tumor and a whole bunch of bad features like, well, extensive lymphovascular invasion, but they weren't grade 3, and they had 2 positive sentinel nodes, yes, then in that patient, you might say, I want to do it, but I think adopting this as a general concept is causing more morbidity than benefit.
Okay, let me push you. What about omitting axillary staging altogether? In patients where you might be considering, we're going to be giving these CDK4/6 inhibitors increasingly.
Well, I think, again, if axillary staging isn't going to change your mind about what you're going to do, then you get into the do you need it for local control question. And again, you get back to how often is there a heavy nodal disease burden. As the T size goes up, that goes up. Preoperative ultrasound is a nice way to exclude the presence of lots of bulky nodal disease. It has a false negative rate of 50%, so it doesn't exclude microscopic nodal disease, but as we've seen, nobody got very exercised in the sentinel node era when the false negative rate of a sentinel node biopsy was 10%, and the incidence of axillary first failure was less than 1%. So we don't have the data to say you can do that right now. Some of the other trials will include T2 patients, and I think that will give us a real-world answer to that question. I suspect we're going there.
Microphone.
Hi, Melanie Sheen, New Orleans. This question is primarily for Dr. Kalinsky, but anyone can answer. So in the anthracycline debate yesterday, the question was posed of a young woman with a 1.8 centimeter node negative breast cancer, and the majority of respondents opted for an anthracycline. In patients, say this is an ER positive patient with one node positive and a oncotype score less than 25, with one node, are you opting for an anthracycline?
So, we have data from the NSBP studies where, for the patients who had 1 to 3 nodes involved, and again, this was in a cohort of patients, a subgroup of patients, where it didn't seem like there was a benefit of anthracyclines in that cohort of patients. I will say in responder that the premenopausal cohort had a higher rate of anthracyclines. It was, in the mid-50s or so. I will also say that the recurrence score is not a predictor for who benefits from anthracycline or not. And I will also just give the caveat with what Dr. Winer and myself had said, just in terms of our patients who have node-positive disease, and then the utilization of CDK4/6 inhibitors. In these patients, I have really moved away from giving anthracyclines. I guess the question is if you had a very, very young patient, but still I tend to move away from giving anthracyclines, given the other agents that we have to help improve outcome.
Eric, anything to add to that?
Agree.
There you go. Yeah, the truth is, I think, you touched on this, which is you're having the conversation with the patient, right? I may challenge the strict literal interpretation of the responder results. They are actually the results of responder, which did not test OFS, it tested chemo. That's okay. So, but, the reality is that you're going to have the conversation that I'm going to have, that all of us are going to have, and say, here's the magnitude of benefit. There's certainly uncertainty of whether you can get at least partly, if not all the way there with OFS. There's debate about that. And then the patient will help decide. That magnitude's likely to change as we have other tools to also reduce the risk of recurrence that are coming, and that includes CDK4/6 inhibitors and other things. So these are, in fact, nuanced discussions, and the shades of gray keep changing. Bill?
Yeah, Saikov from Rhode Island. So I want to address a question to Drs. Thomas and Sharma. And this is in regards to a study that Dr. Sharma did bring up, which is the pattern trial. Here we have a 650 patient study that compared weekly carbotaxol to FEC followed by docetaxel in triple negative breast cancer, including patients with T1 lesions, that showed a 35% improvement in disease-free survival and is less toxic. So tastes great, less filling. When we had the session about anthracyclines yesterday, and a question was asked about a stage 1 triple negative breast cancer, the choices were TC or ACT, and it's like none of the above. I recommend people try this regimen. I'm curious if you've had experience with it and what your thoughts are about it.
So I've certainly tried it. And if I have a patient that I'm going to treat in an adjuvant fashion, my approach is neoadjuvant, as you heard, with T1C triple negative breast cancer, and I have to choose between the regimens. I would choose the regimen that was studied in patent because it was superior to CFD And we know from the ABC studies that tax-AC was superior to TC times 6. But as you pointed out, it is not very widely adopted, and I often see patients where the choices were only those two and not a third choice that was presented.
We have one question from online that I'm just going to pose, and Alexandra, maybe you could take this one. TILs. So the question was, for clinical use, what's the cut point?
I wish we, as I tried to, thank you so much. As I tried to elucidate, we don't have clear guidelines in this space yet, and why I'm sort of begging us to start trials. Even Dr. Sykov's answer is, yeah, that looks great and feels good, but we don't have high quality data. I think in our tumor boards, I ask my pathologists all the time, what's your percentage? We don't have clear guidelines, we don't have consistent validity across labs on this in a way that we'd like. Different centers do it differently, so more organized data. I don't have a specific cut point. It's sort of my gut. Is the patient's immune system trying to fight the tumor or not? Certainly 40% is higher than 2%. And low TILs does bother me.
Support your trials that are examining this. So I want to thank this panel for really terrific talks and great conversations, and all of you for coming. Thank you.